I feel that perio-ortho is probably as important, if not really important, in the sense that, we're dealing with teeth that are in the tissues, and you're moving teeth through these tissues, and I think it's good to have a kind of a background of that. I try to be very straightforward and honest with our patients and say, this is really a cosmetic situation. Certainly, we'd love to help you, but it's not a necessary thing. People don't always remember these things, and we tell them a lot of information. They're getting a lot of information. We assume a lot of times that they understand it like we do, and they don't.
Get ready for your unofficial dental hygiene podcast. These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists. This is episode number 180. My name is Andrew.
And my name is Michelle. Another week of getting better sans wine. Thank you guys for asking and being very concerned about my wine intake. I'm 21 days sober at this point.
Oh, I don't think you get a chip for that yet, though, right? Don't you have to go a full month before you get a chip?
Oh, man. On these hot days, rosé. Oh, I miss you, but it's all right.
That's all right.
Getting closer to the day I can have it.
We have a fantastic interview for you guys. This is going to be continuing on like the mini
specialty series, right?
Specialty series.
So we're calling it. Yeah.
This one's going to be all about orthodontics. But before we get into that, I want to read just a couple of quick iTunes reviews. Thank you so much for Lippy872, who said valuable information that can be applied same day at work. That was very nice. 5 stars. And also for, it's just by hygiene student, which I don't know how no one else has had this before you. It just says hygiene student and no other like numbers or anything. So well done on that one. It says phenomenal podcast for dental peeps, 5 stars. This podcast is not only for you to learn how to take care of your patients, but it's to learn how to take care of yourself too. Truly, listening has made me a healthier and happier person. I am so excited to share this podcast with every healthcare person I know. You don't have to be a hygienist to love it. So thank you, hygiene student.
And as we were recording today, we got an email from Pam, and she said, I am hooked on your podcast after the airway series and the cariology series, which were amazing. So I totally agree. So good. I appreciate the quality evidence-based CE delivered. Thanks so much. No, thank you. Thank you guys for sending all these in and writing your reviews and rating us. We do appreciate that.
And thank you also, I would say, before we keep going, thank you to the professionals that gave you the top quality CE that we just delivered on our platform. So
amen. That
was really all attribute to them. So thank you to them.
Absolutely. And this one is going to be another great evidence-based course. We really wanted to dive into some of the specialties maybe we didn't hear enough about in school, or maybe you never even thought about looking into or encountered. Sometimes we see patients that have ortho or these aligners, and we know just the bare minimum. And so we're going to do a little bit of a deep dive today. And so Dr. Bryan Green was nice enough to come on, and we had like at least 15 additional questions. So one day maybe we'll even have an ortho series on just that. But enjoy this particular episode with Dr. Bryan Green.
Hey, Michelle.
Yeah.
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
All right, listeners, we are excited to continue this series where we kind of talk about some of the specialties that we might not be seeing on a routine basis. And one of them is orthodontics. We have Dr. Bryan Green with us today, who is going to kind of fill our heads with all things ortho. So welcome, Dr. Green.
Well, thank you so much for having me.
And tell us a little bit about yourself and where you're practicing.
I've been practicing as an orthodontist for about 10 years. I graduated from dental school in 2000, and before I became an orthodontist, I actually did a residency in periodontology at the University of Tennessee in Memphis. And I practiced for 3 years with a friend that I had graduated dental school with. And then in 2003 is when I had finished my my periodontal residency, and then practiced until 2006. And then at that time decided to go back and do orthodontics as well. It was kind of unusual. A lot of people feel like that there's more of a pedo-ortho combination, kind of dual specialty, but I feel that perio-ortho is probably as important, if not really important, in the sense that, we're dealing with teeth that are in the tissues, and you're moving teeth through these tissues, and I think it's good to have a kind of a background of that. I actually got excited about it. I had gone to a perio-ortho symposium in Boston. I think University of Penn has a dual train program where it's a 4-year program where you can actually do ortho and perio at the same time. I unfortunately did it kind of the backwards way, where I did a 3-year perio residency and then practiced for 3 years, and then went back and did almost a 3-year residency at Medical University of South Carolina in Charleston. And then I got out in 2009, and like I said, I've been practicing for 10 years in Bowling Springs, South Carolina, which is kind of on the outskirts, kind of north Spartanburg, if you will, in South Carolina. And when I finished my program at South Carolina at MUSC in orthodontics, one of the attendings, the chair of the department, asked me to stay on and teach part-time. So, of course, that was kind of a great opportunity for me to kind of stay in education and kind of give back what I'd been so lucky to kind of be a part of. So I now go back and teach at MUSC in the Department of Orthodontics one day a month. I just worked with the residents at that time, and just kind of, we talk about, any and everything. We pretty much just get cases and treatment plan those cases, and then kind of work them up. So that's kind of a little bit about me.
Doctor, I was going to ask you a little bit about the different types of programs or residencies that they have for orthodontists. I feel like a lot of our listeners are going to be coming from private practice where their doctor did the very routine. We go to our undergrad, we go to dental school, and then we're done. What kind of things are you learning in the programs or residency programs for ortho?
So for ortho, well, I guess, just to kind of, on the basics, obviously you do your undergraduate in a college and get all your prerequisites to get into a dental school, and that typically, you can get into dental school after about 3 years if you have you can get an early acceptance, but then you do your 4 years in 4 years in dental school, and then you apply for orthodontics, and a lot of the orthodontic programs are around 2 to 3 years now, and it really depends on whether or not that program offers a master's degree with your certificate. I think a lot of people get a little confused about, you get your doctorate degree from dental school, and then when you become a specialist, you actually get a certificate in that specialty. You don't really get a degree. I think a lot of people always feel like I have a degree in orthodontics, and I really don't. I have a degree in, I have a doctorate in dental medicine, and then that gets confusing too, because some of the colleges have a DMD doctorates, which is kind of a doctor of dental medicine, and then you also have the DDSs, which is exactly the same thing. It just depends on which university you go to, and that's a doctorate of dental surgery, and they mean the same thing. I thought maybe at one time it's kind of a locational thing, but I think it's just what the universities have always had, or whatever it may be. But a DDS and a DMD are really actually the same thing. But then when you go on to a specialty program, you actually just get the certificate in that specialty, and then of course you can go beyond that and get board certification, which is basically the American board of whatever that specialty you're in, and you have kind of a 2-part process where you do a written exam, and then you come back and you do an oral exam. And most specialty programs require, as part of graduation, that you can successfully complete that written portion of that board certification just to get to graduate. And then a part of that certificate in that specialty, you can also get a master's, and the master's could be in a number of different things. Where I got my master's degree came from the University of Tennessee, and it was in dental science. So I have like a master's in dental science, and that was when I was doing my perio residency. When I did my orthodontic residency, at that time, we did not require a master's as part of that graduation process. But now in Charleston, at USC, we do require that you get a master's degree. And so I don't know if that was helpful or what you were looking for.
Yeah. Actually, that was nice because Dr. Tony Stefano always gets on me because I might mislabel a DMD versus a DDS. And he's like, they're not the same. I'm like, okay. It's as picky as probably us being called a dental assistant versus an RTH.
Yeah. It's just kind of silly. I've never really understood why one, because most medical doctors are all MDs. And, I don't understand why all dentists are not considered DDSs or DMDs. It just really depends on the university and what they want, what doctorate degree they want to give you. But at the end of the day, it doesn't really matter. You're all dentists. I mean, that's what, that's our profession. So
I would like to start with, because again, we're talking to students. We even have a few people who are waiting to get into dental hygiene school, and all the way up to veteran hygienist. And so I would love an introduction or a recap of why do we have ortho? What's the point and what are we trying to accomplish with orthodontics?
Orthodontics is actually the oldest specialty in dentistry. Believe it or not, it was the first dental specialty. And a guy by the name of Dr. Engel is the one who, started teaching the specialty, and he would just get the, dentist, recent graduates who wanted to do something a little more specialized, I guess, and as far as alignment and things like that. So that's kind of where our specialty started, by the name of Engel, Dr. Engel. So, but
is that the Engel's classification?
That's correct. And
okay.
That was Dr. Engel, as far as different types of classification, where he came in and said, this is how teeth should fit and to be in proper function and so forth. But I think to kind of look at it as a broad picture, if you will, is to consider, why alignment? Why does it matter? And I think alignment and having, other than just the cosmetics of having straight teeth, I think there's more to it, such as function and then stability and then health. I mean, there are research studies that we had to read a lot about, that I don't think you get periodontal disease from having a malaligned dentition, but you do. It is more difficult to clean, malalignment. I mean, if you have really crooked teeth, and people aren't flossing, so let's face it, not everybody flosses, and on a regular basis. I mean, you just can't really get all in the nooks and crannies, to clean those teeth. So, having a well-aligned dentition helps a lot, especially when it comes to, hygiene. I mean, that it just makes it a lot more simple and a lot easier to just to kind of clean those areas. And then you get into function. I mean, we talked about Engel's classification, a class 1 where you have the upper cusp, distal to the lower cusp, fitting in those grooves, and then you have something called canine guidance. I mean, we feel like that, the way I was trained, that when you go into excursive movements, so when you're kind of moving your jaw from side to side, you want to kind of rise off that cuspid or that canine, and you get disclusion or opening in the posterior sections of the mouth, and that's really when you have that, that's just a good bite. It's a good occlusion to function off of. Then you can get into, as far as function, do you have a more protected, with that protected occlusion, do you have a more healthier joints? And there's a lot of debate about that, and I feel I have different opinions about that. I do believe that if you have a very good functioning occlusion, that you would certainly have the best, I guess, situation to have a healthier joint. But then I think you throw in stress and things like that. I think that does create a little different situation. But certainly health of the joint, and having a good functioning occlusion, I think, are paramount. And then certainly you go into the cleansability issues, the stability issues of just being able to maintain. I think when you have very nice aligned teeth, retention is very important, as after you've had some form of orthodontics. But, if you have a very well-aligned dentition, then certainly that it in itself is its own retainer, and it holds everything into place. And I think if you just have a better overall result. Certainly one of the things that I strive to in all our patients is not only to have the cosmetic result, but certainly have the functional result. You have a little more stable occlusion for, hopefully for a lifetime. And then certainly just the cleansability issues that come along with aligned teeth.
Doctor, would there ever be a reason to not pursue orthodontics?
I learned this when I first became a resident. And it's something I kind of live by a little bit. And it sounds kind of crazy and funny, but nobody died from crooked teeth, and my point is that everyone that walks into my office, I don't push, orthodontics or straightening teeth. I mean, a lot of people, they come in and they ask me, do I need orthodontics? I'm like, I got to be honest with you. Other than the really extremely mutilated dentitions and certainly, when I say mutilated, I'm talking about severe malalignment, with when you're hitting and they're not hitting appropriately, and it creates a slide, premature contact, if you will, where they're biting on a tooth and it causes their jaw to kind of slide to the side. I mean, those cases really, especially in a young patient, those really do need some attention. A cross bite, anterior cross bites, where you have kind of that bulldog appearance, if you will. We call those class 3. And then certainly posterior cross bite, where they're biting and their upper teeth, instead of sitting on the outside of the lower teeth, they're sitting on the inside of those teeth. And those sometimes will create that, when I said that, premature contact and a slide. And you worry about that in younger patients, specifically where when they have unnatural growth because of that slide. You'll grow asymmetrically because as you bite, kids don't want to bite on points. They don't want their cusp tips hitting each other. They want that cusp tip to sit down in a groove somewhere. So in order to do that, it causes your bite to shift to the side, to the left or the right. It just really depends on the patient's comfort with that. And then they'll get a little asymmetric growth from that. So, those type of things I do feel like warrant treatment, but just for the cosmetic purposes of it, like again I said, nobody died from crooked teeth. So I try to be very straightforward and honest with our patients and say, this is really a cosmetic situation. Certainly we'd love to help you, but it's not a necessary thing. Another thing, in adults or even children, when they have very proclined upper teeth, those you worry about as well, because you worry about trauma. When they fall, they may tend to puncture their lip or really fracture the incisal edges of the upper teeth. Those are situations too that kind of warrant some, or maybe even early treatment in a young patient, or just treatment in general with an older patient. But yes, I said it's a really difficult question sometimes when people say, do I need to have my teeth straightened? It just depends on what kind of what their malocclusion is and what their situation is and those things. But I think the three main ones, I think the takeaways, especially with our colleagues, the hygienist colleagues, I would think the one thing takeaway is that cross bites, either posterior or anterior, those are really troublesome and certainly want to be treated as early as possible, especially in young patients. And then also extremely proclined teeth, where you would be concerned about them bumping or fracturing or puncturing their lip, some type of trauma like that. Those are the three main big red flags that you really, really want to get them over, or at least have the dentist or someone just evaluate and at least speak to them about having that corrected. The sooner you correct these problems, I think the better, especially in growing patients. You know, the American Academy of Orthodontics always recommends that we see these patients at the age of 7, not because we're trying to get them in and, we got to, spend their money, but mainly because we're just trying to diagnose anything that may be able to be corrected very, very easily, by putting an expander in for like a posterior crossbite, or especially the anterior crossbites. Those are difficult. Those are very difficult because they're typically a skeletal problem. They're not just a dental problem. And so those are things that you really have to be, you really want to be more proactive on.
So for instance, as a hygienist having these conversations, what is kind of resonating with me is a crossbite. I've always been like, oh, you're just, eventually you could create disease around that tooth because you aren't hitting that cusp into the fossa, or you're hitting cusp to cusp. Or I've never really had the conversation about the shift creating that asymmetry in the face. And is that being caused because maybe one of the ramuses is being shortened and the other one is being slightly elongated as they're growing because it's shifted?
Absolutely. So, absolutely. And what happens is it starts out, I guess the etiology of the problem has a lot to do with the maxilla, the upper jaw is not wide enough, does not have enough width to overlap the lower jaw or the mandible. And then what happens is it looks like these patients tend to have a unilateral posterior crossbite as opposed to a bilateral posterior crossbite. The truth of the matter is how you address this and how you actually look at this is look at the patient and then see if the upper and lower midlines match up. And so if the lower midline is usually off to the side of the posterior crossbite, and then what you do is if you just take that patient and you just say, okay, don't bite down completely. Let's just try to manipulate your lower jaw such that we get the upper and lower midlines directly, centered. Okay, assuming that the upper midline is on the face. And I would say that 9 times out of 10, when you line up the midline, they actually end up having a bilateral posterior crossbite. But what happens is, again, like I was talking about before, they're hitting cusp tip to cusp tip. And then people don't function on cusp tips. They function on cusp to fossa relationships, whether they're in a malalignment or not. So we like to fit points into grooves. So you're not going to hit tip to tip or point to point. So that patient, and a young patient, will actually shift their jaw left or right to allow for you to get a cusp to fossa relationship. And you can tell this, the crossbite will be on the side that the midline is off to. So if they're biting and their lower midline is on the right, it's shifted to the right, they're going to have a posterior crossbite on the right. But they're actually not, it's not an asymmetrical thing. A lot of you look at it and you say, well, they're on the crossbite on just that right side. And you say, well, that means that they're just a little bit short on that right side. Actually, they're short evenly. They're just shifting to that side. And then go back to your point you made about the mandible or the condyles, the ascending ramus being a little shortened. Absolutely. What happened, that's kind of like what you were saying was kind of what happens, due to that functional shift. They will get longer on the side that they're shifting away from, and they'll stay short on the side that they're on the crossbite side. So the crossbite side, the ascending ramus will stay shortened, and then the side that they're shifting away from, so like in this case, this situation, the left side would actually be longer. And so you would create an asymmetry through just growth because they're shifting over to that side. And then I feel like that eventually creates, joint problems as well.
So when we are assessing young patients and young children, do you think it's just a good idea across the board to say once you hit 6 or 7, maybe seeing an orthodontist, or are there very specific things that we are looking for in assessing and saying, let's catch this earlier, get you to an orthodontist early so we can make these adjustments easier?
Absolutely. I think the hygienists are like our first line of defense always. Always, always, always. You guys are kind of in the trenches fighting the war. You're seeing the patients. You're kind of spending a lot of time on them. Not that the general dentist is not coming in. I don't mean to take anything away from that. But you guys are establishing relationships with these patients. You're kind of talking to them. You're spending a lot of time. You're triaging everything. You're kind of, the front line there. And so absolutely, I think that you guys can pick up on a lot of things. My assistant, my dental assistant, pick up on a lot of things because, I'm jumping and I'm looking and from chair to chair and making sure that the treatment is progressing well and so forth. But they're the ones, they're looking and they're like, well, the hygiene is not really great, or they're not wearing their elastics like they should. I just noticed that they've got maybe a carious lesion on such and such. I mean, so you guys are definitely going to be able to pick up on a lot of things. And I think a takeaway, certainly, some of the big takeaways are the three things that we spoke about earlier on these young patients. If they have a posterior crossbite, whether it's bilateral or unilateral, that's something that we want to see them, around the 7-year mark. Not because we may do something right then. Usually I'll see a patient at 7 and I'll be like, yeah, we're going to do this, Mom. Because typically a 7-year-old, they may have their front permanent incisors and then their first molars, are probably erupting, or certainly they're erupted, and then they're getting their incisors at that point. But they still have the primary cuspids and the primary first and second molars still present. So that is something that, I'm just evaluating the situation, seeing that can the patient, even if they were mature enough to have the treatment, are they ready for the treatment and things like that. Even if they have the problem, sometimes I'm waiting to make sure that they're going to be ready for treatment. They're going to be able to maintain, a good oral care during this treatment, and it's going to be a good experience. That is a big, big thing, I think, now that we really pay more attention to, is making sure our patients have a good experience. Sometimes, even if they need it, but they can't tolerate the treatment at that time, it's not worth doing, because then they're going to have a terrible experience. We're going to give them maybe some emotional problems down the road where they don't trust the dentist or the dental team at all, and that I just don't feel like is the right thing. And then certainly it could be just that, hey, we're just going to get them in a couple of times and just establish some trust between us, and then they may be ready. But certainly getting those patients over with the posterior crossbites, anterior, kind of like I said, where their lower incisors are starting to kind of get in front of their upper incisors, like the bulldog look, and then maybe the situations where they have a thumb habit and they're creating a lot of proclination of those upper incisors, or maybe they just genetically, they have really flaring upper incisors and we're worried about some form of trauma or something along those lines. Those are kind of the red flags, the three little red flags that you really, posterior crossbites, anterior crossbites, and proclination of the upper incisors. Those are really, really big things that I think that you guys can start assessing and kind of really say, hey, listen, I think that orthodontics may be in your future, and we have such and such. We want to just have you go and take a peek. They're not going to charge. I don't charge for new patient exams, and I don't even after they come in and they're on a recall, even if I'm not doing anything and I bring them back every 3 to 6 months, I'm not charging them. I'm just trying to see if the problem is something that we need to do something about then, or if we do, then can they tolerate it? Are they emotionally ready for this type of treatment? Can they manage their home care with these appliances on? I think those are really, really big things. And then to go on, I kind of mentioned thumb habits. That's another one that you guys can really, really help out and really diagnose and notice a lot quicker than I will, because I'd say you guys are the first line of defense. So those are things that we need to kind of start trying to nip in the bud, because the sucking action of the thumb is going to create a posterior crossbite or a constriction of that upper jaw, and certainly it's going to flare the upper incisors and retrocline or tip back the lower incisors. And those are just, bad habits, certainly, that are much more difficult to treat in a late teenager after the effects have already occurred. So those are, I think, some things that are good takeaways, I think, that you should be looking at.
Doctor, I'd like to prepare the hygienist listening to this with information on how to explain to their patients what a consultation appointment would look like. So, for instance, the dentist has already come in, agreed with all of the treatment options, and said, hey, we're going to send you over to see the orthodontist. Once the patient gets to you, what are some of the assessments and things that you do on that first appointment?
So one of the things, once they've assessed them and sent them over, I usually like to request any radiographs that they may have, especially any type of, if you have a pan, I really want to see that, just because I want to see, are there missing any teeth? Do I see any teeth that look like they're getting ready to get impacted or anything like that? So certainly once the referral is sent out, I would also ask that, hey, send us your most recent pan. The bite wings aren't as helpful. PAs are helpful, certainly, if there's an impaction problem. But I think, the referral, the initial diagnosis, and then any radiographs, again, a pan would be very, very helpful. But the patient comes in, and then I introduce myself, and some of my staff, my team have already introduced themselves, and certainly we just kind of come in. I'll say, how can I help you? What are there any concerns and anything like that? And I just kind of want to see what they know, and you guys have already told them that, but I want to see if, hey, do they remember, or do they know why they're there? And sometimes they know, and sometimes they're like, I don't know why I'm here. But and the funny thing is I know they've been told. But, people don't always remember these things, and we tell them a lot of information. They're getting a lot of information. We assume a lot of times that they understand it like we do, and they don't. I'm the same way. I go to someone else's practice, whatever it may be, and whatever, they do, and they're telling me a lot of information, and I'm like, wow, I got about half of that. Maybe I got a fifth of that. Then usually I look to see if there's any type of referral. I find out where they're coming from, what doctor, and so forth, and then I go through, and my staff have typically taken some photos, and they'll have those up for me. And then if any radiographs have been sent, they'll have that. And so I'll go in and I'll say, we're just going to count some teeth, and we do it a little different than maybe the dentist did, because in orthodontics, I don't know why we do this, but in dentistry, they use the universal numbering system, 1 through 32. Whereas in orthodontics, we don't count like that. And it was very difficult when I went from perio to ortho, because I was used to thinking that 1 was, the upper right third molar. Well, 1 in orthodontics could be the central incisor on the right or the left, or the lower central incisor on the right or the left. And so sometimes we'll screw up, and we'll send a note like saying, hey, please, evaluate upper right 1. Well, upper right 1 could mean tooth number 1, which is the upper right third molar. But for me, that's actually tooth number 8. Upper right 1 is tooth number 8. So that's one thing that, I think maybe hygienists may not know that. And maybe some dentists don't even know that we upper right 1 is tooth number 8, and upper left 1 is tooth number 9. And so we'll number, the central incisors. Starting at the central incisor, we number it 1 through 7, and I say 7 because typically they don't have the third molars, and we just go straight back, and it's either upper right or upper left, or lower right or lower left. So I'll tell them, hey, I count kind of funny, and then of course we number, and we number the primary teeth by letters, certainly, but we do it again by saying A, B, C, like upper right A, or upper right B is actually the upper right A would be tooth number E, so
I'm glad you knew that, because I was like, oh, I don't know which one.
Yeah, so upper right A is actually E. So, but anyway, that gets kind of funny. So I'll go through, and I'm saying all these numbers, and I'm like, I'm counting backwards, and I don't really know my numbers or my alphabet, and so they're kind of laughing, and so, but at the end of the day, we kind of get the numbers, and so I count the teeth, and then I'm looking at their bite, and I'm kind of assessing how they're biting, and then I'm looking at their overbite and their overjet, and then, everybody says, oh, I know I've got an overbite, and I'm like, well, actually, yeah, you do, you're right, they told you that, and that's right. But overbite, in layman's terms, people think it's just an overbite. Well, it's actually assessed the vertical component of it and the horizontal component of it. and they'll say, hey, there's actually two parts to it. It's how much your teeth stick out from away from your lower incisors, and then also how much overlap you have. So overbite is the horizontal component, the overlap part of it, and then overjet is the actual horizontal distance. It's the gap that's between your upper and your lower incisors, that space there. So we'll go through that, and then look if there's any cross bite, and then certainly then evaluate the radiograph and see if there's any impactions. Are all the teeth there? Are they all forming? Because nowadays, I got to tell you, I see more and more kids with missing permanent teeth or agenesis of those teeth, and that you kind of want to start telling the patients about that, and at least saying, hey, they're not showing up now. Maybe they'll show up. But typically, if they're not there by 15, they're not coming in. They're not going to develop.
I was just curious why we are seeing, and if it's outside of the regular max lateral incisors, and what was the other one? What's the other common one? Molars.
So the most common missing tooth are lower second premolars. So I got to think about this. Tooth number 20 or tooth number 29.
Yeah.
I have to think about that, because I would say lower 5 is what I would say. Lower right 5 or lower left 5. And then second would be the laterals, and then, of course, your third molars are kind of in there. So that's kind of the big three. The third molar's missing. Wisdom teeth are missing sometimes. And then you have your lower second premolars are the most commonly missing tooth. And then second to that is the upper laterals, the maxillary laterals. So why that's occurring, certainly it has a lot to do with genetics. There's some theories out there that certainly we're just evolving and our diets are changing, and we're not, chewing rocks and, eating bones
epigenetics
and all this jazz anymore.
And everything.
Yeah.
Yeah.
Yeah, I think it does. I think it really does play a role. And certainly, then I'll ask questions like, Mom, Dad, are y'all missing any teeth or anything like that? And they'll say, yeah, I'm actually missing, my lateral or whatever. And I had to have an implant, or actually they substituted my cuspid for my lateral. And so those are really big things that we're just trying to get out. And then certainly, are there any habits, going on, or that are affecting or maybe contributing? What's the etiology of the problem? What's causing this? Is it because they've been sucking their thumb and that's why they got a crossbite, or their teeth are flaring, or they, then you can get into a lot of the breathing, breathing problems. Are they mouth breathers? Do they have enlarged tonsils and adenoids? Do they need to kind of be being seen by an ENT? That's kind of a new thing that we're kind of airway is huge, kind of a buzzword now, certainly that we've been trying to assess. I'm really big into airway. I like evaluating airways and certainly seeing, are they constricted? And because I like to expand patients, certainly because I feel like that opens up things and helps with the turbulent flow in the nasal passages and so forth. So that's kind of a typical exam that we'll go through, and then I kind of put them up and I say, hey, that wasn't so bad. No, it wasn't so bad. I told you it was going to be your easy, it's going to be an easy appointment. And they're like, yeah, it was. And then we just start talking, okay, Mom, this is what I found, or Dad, this is what I found. And in layman's terms, this is not fitting well together, and this is what I think we should do, for that. Or I think at this point, let's just watch and wait. And then I'll tell them a lot of times, hey, let's just, the KISS principle, keep it simple. You don't always, every nail does not need a hammer. And I tell you, I've never been sorry for waiting with treatment, but I've been sorry that I've started too early before, because you get, maybe they wasn't ready for the treatment. Emotionally, they wasn't ready or whatever. But sometimes just watching and waiting is a good thing. You've kind of diagnosed it. You kind of know what's going on. You make your notes. You say, hey, let's come back. Let's just see if things change anyway. Or sometimes they're not going to change, but you're just kind of buying some time just to let them, get a little more emotionally fit for any type of treatment. But then there may be a situation where they're ready for treatment, but they're not ready with their home care. I mean, that one of the more difficult things I deal with in my practice now is not necessarily the case being so difficult that we can't treat it. I typically, and I would say most orthodontists kind of know how to treat the cases, whether or not the patient or the parents accept our treatment plans, and we have to do a compromise treatment plan. That's another situation. It really has to do with compliance with the patient. If you want to be successful in orthodontics, you've got to have compliance, and that means they've got to brush well. They've got to eat the right foods and not, break the brackets off all the time, and, just kind of, follow the guidelines that we kind of set out for them. And honestly, the truth of the matter is most kids can eat most anything they want. The reason why we don't want them eating the chewy and crunchy things is sometimes they don't understand that the forces they can generate with just biting down on things. And if they got something between their tooth and that bracket, the bracket's going to give. It's meant to give. We don't want to break the tooth, because eventually we got to take those brackets off. So if we glued them on so hard they would damage the enamel, I mean, that would be, that would not be good. But my son, he's actually getting ready to get out of braces, and I can assure you he ate everything he wanted. And I may think he maybe had 2 brackets in 2 years. I mean, so I know that they can eat most anything they want, but it's typically the habitual offenders, if you will. They're the ones who are not brushing well, they're not wearing their rubber bands, and they're always breaking brackets. And I think you could get into saying that I do believe that when they're not brushing well and they have a lot more inflammation and a lot more gingival clavicular fluid expression, just from that inflammation, I think that just eats away at our bonding. And I think it really does just loosen the bracket a little bit more, because I have the kids that are breaking brackets all the time typically have poor hygiene. Now, there will be the occasional one that are going to break a bracket because they ate the wrong thing, but those brackets are typically the lower brackets. But if kids are breaking upper brackets because, the upper cusp, or overlap, the lower teeth, so the uppers typically don't get broken unless they have some bad habit, like chewing on a pin on the top brackets or something like that. But certainly, eating the wrong food is going to typically be a lower premolar bracket, or maybe a lower second molar bracket. But the ones that are always breaking brackets, they typically have poor hygiene. But going back to the, starting, I won't put brackets on anymore. I've been practicing for 10 years, and I'm at a point now where I'm like, it's not worth it. It's just, I'm like, I'm not even going to start your case until you can demonstrate that you can, maintain some good hygiene. And so we'll put them through a 2-week reevaluation program where we're kind of watching them and making sure, and they'll come in and they'll keep, no, you're not ready. And eventually they'll get it. And if they don't get it, then, they're not going to get braces. But most of the time they'll get it, and then they'll understand that they got to kind of earn it, so to speak. And then we'll start. But, occasionally that patient will come back and they just kind of fall back into bad habits. And, we're constantly, grading them and encouraging them and showing them and demonstrating to them. And I'm writing letters back to you guys and saying, hey, just so you know, we're on this. We've been talking to them and so forth. And maybe even try to set up maybe even more shorter intervals with their recalls with you guys, just to kind of get everybody's eyes on them, so because that's one of, like I said, the hardest thing that I'm dealing with right now is hygiene and then course compliance with their elastics and so forth. So.
I'm curious, what role does the parent play in that home care? Because I know for us, we are encouraging parents to be brushing teeth until like 9 or 10 in some cases, depending on what kind of fine motor skills that child has.
Sure.
So is that something that is also, like, if you do have that 7-year-old that's maybe not compliant, I mean, is that a non-compliance with the parent, or is that a non-compliance with the child?
I think it's both. It's both. These kids are learning it from their parents. If their parents don't, put a lot of effort into their home care, then, it's unfortunately just a bad situation, a trickle-down situation. But, sometimes you can get the parents to get on board, and certainly that's what we're doing. We're having the parents and, involved with this, and we're showing them, we're telling them, hey, you got to help these young people out and your children out. But it's not always just the younger. I find sometimes the younger patients are actually really willing. They want to please you. The young patients really want to do a good job. It's really the teenagers that I think once they get past that 13, 14, maybe even 15, they're the ones that are probably more difficult. And the parents at that point are saying, hey, he's 15. He should be able to brush his own teeth. I can't do anything with them. And then I'm like, wow, if you can't do anything with them, I certainly can't do anything with them. I was like, but my job is to point this out and show you, hey, you're going to have some irreversible damage to your teeth that we can't fix. And I was like, I'll give you straight teeth, but pretty teeth, good-looking teeth are totally up to you because I can't brush your teeth. Sometimes they'll get it, but sometimes they don't, and then they just kind of squeak by until the end, and then they're upset that they see spots on their teeth. And, I've had, there's been many instances where I've just taken them off and just said, hey, we can't do this. We can't continue on until you can demonstrate better habits and so forth. And it stinks. Nobody wins in those situations. I mean, we're all losers in those situations, and it's just terrible. But certainly I think education is hugely helpful, and then certainly just talking to the parents, making sure they are aware of what's going on. Communication is just the key.
So there's a few topics I would love just to touch on before we wrap this up. And one of them, I know a topic that we're probably being asked a lot by parents and patients, brackets versus trays. Like when is the proper time to be using or recommending brackets? How do trays work? And who are the people that maybe are not the best candidates for those?
Yeah, it's a great question. I mean, aligners are certainly a very big buzzword, and certainly in the media now and TV commercials about do-it-yourself aligners and so forth. And I think all this has a place. I really do. I'm not one of those that gets really fiery mad about certain things. I mean, certainly about people wanting a more economical method of getting, alignment and so forth. And I think it all goes back again to what will the patient do for you? How compliant are they going to be? Because aligners require a lot more compliance than brackets, because you don't have to think about brackets. They're cemented to your teeth, they're bonded to your teeth, and aside from keeping your teeth clean and wearing rubber bands, they don't really have to think about it. They don't have to take the liner out to eat and then put it back in, and then certainly go take them out to clean and then put them back in, after they've done their hygiene, and then sleep in them and so forth and so on. So I think first and foremost, just looking at the big picture, what can the patient tolerate? Because the truth of the matter is we can treat very young patients. I have very young patients, 8, 9-year-olds in aligner treatment, and they have done very, very well. And I think, again, I kind of mentioned this earlier, sometimes the younger patients are much more compliant and much more willing to please you, as a profession. They just want you to be happy for, excited that they're doing it and doing it well. But then I'll have teenagers and adults even they're paying for it. That's not the teenagers, their parents are paying for it, that they will not be very compliant with the aligners, and it will not work. Brackets are cemented on your teeth 24 hours a day, and aligners need to be worn about 22 hours a day for it to work. Teeth like slow, continuous movement. Teeth do not like fast, rapid, sporadic forces in general. So when a tooth is moving at its optimal place, it likes to move very slow and continuous and light pressure. So if you're wearing an aligner or wearing braces with a really flexible wire, you're getting that optimal force levels that you need to move that tooth appropriately. But if you're just, again, wearing rubber bands kind of sporadically, you're just putting that force on and then you're taking it back off, and you don't wear it for a day or two, and then you put it back on, your teeth aren't going to move very well with that. And same thing with aligners. If you're just popping the liner in, wearing a couple hours a day, and then trying to switch the next aligner, that's not going to work as well either. So, but let's get back to aligners, because I think there's so much to understand about it. With brackets, brackets are placed on teeth, and then you use a wire as the force level to actually start aligning a teeth. You have to understand that when you put that bracket on a tooth, that bracket has all the movements kind of a average movement to put that tooth in the final position from day one. And you're just going through these different wires, these small, light, spaghetti-like wires, to build up the force levels to eventually move that tooth to that final position. With aligners, that aligner only is moving that tooth about 0.2 of a millimeter, and that's it. People start getting the aligners and they're saying, my teeth aren't getting straight. And I'm like, well, look at the aligner. Does the aligner look straight? Do the teeth look straight on the aligner? And they're like, well, no. And I'm like, well, your teeth are only going to be as straight as the aligner, if you're wearing it appropriately, is going to take you to that one point. But the aligners, you're getting a new aligner about every week to 2 weeks. And then eventually, when you get through multiple sets of aligners, then you finally get to the final result. And it just depends on, how much movement you needed to correct that. But again, I say, the brackets, you have to think of brackets are actually cemented on the teeth, and they're actually trying to straighten your tooth to the final position from day one, because that bracket has all that movement built into it. We were just using really, really light wires, so it will never express that movement until we get into little bigger wires. As people say, we're tightening up their braces. Well, we're not really tightening the braces. We're just using thicker wires or stronger wires or stiffer wires or more rectangular wires as opposed to round wires. That all affects the movement and the engagement of the bracket through the wire, whereas plastic is only moving that tooth in a certain point, and then it stops. And then you put a new aligner in, and it starts the movement again. But it takes about a week to 2 weeks, depending on the patient, to express that movement built into that aligner at that stage. As far as treatments that can be treated with aligners versus brackets, I tell you, we do a lot of difficult cases now with aligners, but maybe there's some type of a hybrid treatment where we're using some auxiliary, like maybe, a bracket or an elastic on a tooth to help twist the tooth, because we know that the aligner is not going to be able to express that movement completely. So we'll add a little, maybe a little limited brackets in one little spot where the aligner slips over the top of that, and it allows for that to correct, initially, and then we can continue with just aligners. Or maybe they have a crossbite, like we've been talking about earlier with younger patients. I would put an expander in, expand them, and then after we're done with expanding, whereas the traditional way of doing brackets and expander, I would just start with the wires after I've expanded them. But whereas with aligners, I can take the expander out and then finish up with the aligner. So there's different combinations to kind of apply to each case specifically. But you wear rubber bands with aligners just like you would with braces. A lot of people think, oh, well, how does that work? That doesn't work the same. Well, yeah, it does. It works the same way. Teeth don't know if it's a bracket on them or if it's plastic on them. They just know forces. They know that something's putting force to move that tooth, and that allows the tooth to move into the desired position. So, but again, with anything in orthodontics, it's all about compliance. The best cases treated are always going to be the cases where the patients are the most compliant. I don't care who you see, because we can only get so far, and then the rest of the way has to be, it's a two-way highway, it's a two-way street. We got to do our work, and they got to help us out a little bit. So, but we treat all different types of cases, young and old, with aligners, and the same with traditional braces and brackets. I guess to speak a little bit about the do-it-yourself aligners that you see on TV and so forth, I think those things have a place. There's one thing, those companies don't add attachments to your teeth, and you don't have the opportunity to have something called interproximal reduction, or IPR. And what I mean by that is, when I do aligner treatment in my office, we typically put little attachments. They're like clear little buttons, little undercuts, if you will, so that the tooth can, the plastic can grab the tooth in certain locations to be able to make the movement that you need. Those are very important, because if you're just putting plastic and you're trying to move a tooth to a certain degree, you can only take it so far with just a plastic wrapped around the tooth. You'll get a lot of slippage, and you'll get a lot of tracking problems. Tracking is when the tooth's not moving at the same rate that the plastic thinks that it should, or that the plastic, is just sitting there in the tooth. You're moving on through the plastic aligners, the different stages, but the tooth is it's lagging behind. And a lot of that is because you don't have any grip on the tooth. And so whereas a bracket and wire, you have a bracket cemented to a tooth and you have a wire that's locking into that bracket, that's going to move it. It's going to kind of cowboy it into position. But with plastic, you have to be very, very patient for certain movements to occur because they don't happen the same. A plastic is more of a pushing appliance. So you have to think about it when the forces are being applied to the tooth. Forces are more pushing in nature than pulling in nature that you would have in a situation where you have brackets and wires. So you have to look at that. And these companies, they have very good computer programs that will manipulate the movements and allowing movements to occur, but they don't allow for attachments to be placed because you're getting a scan or you're sending in your impression. And then they're just developing a treatment plan, and then they're shipping you your trays to your house. And then you have no one monitoring them other than, going in or taking some pictures, or they may have some type of kiosk or a little office that you can go into. But these are not necessarily always trained professionals that are looking at that. They're just kind of scanning you and sending it off to the company and so forth. And then again, you don't have, sometimes with plastic and even with braces, we have to go in between the teeth and reduce the width of the tooth slightly. We're talking tenths of a millimeter. And you will not get that movement because there's too much crowding. And there's cases where, they have crowding, but you don't want to do any extraction because an extraction is way too much space created. So we'll create the room by developing and widening the arch forms, and also by, making the tooth a little more narrow. Teeth they have a lot of enamel, and approximately, and roughly on average, you have about a millimeter on one contact on one tooth, and then another millimeter on that adjacent tooth. So maybe let's say 2 millimeters of thickness of enamel, and that's in a minimum range. And if you're just taking 2/10 of that, you're only taking 0.1 from one tooth and 0.1 to the other tooth, but that's enough reduction of that tooth to allow that tooth to move into position and actually get alignment. Some of those do-it-yourself systems don't allow for you to be able to have that, but certainly when you come to an orthodontist or to a dentist or whomever who does that type of treatment, we can do those procedures on you and actually to allow that movement to occur and certainly hopefully have a better result. So I think that's some of the things. But for people who just have a tooth out of position and all they want to do is pop it into position, I think it's a fine situation. These companies were established because there's very little, the population as a whole does not seek orthodontic treatment. I mean, it's maybe 30% of the population seeks orthodontic treatment. There's a 70% of the population who may or may not, who may want treatment and just would otherwise not even go to see a dentist or an orthodontist. So they're trying to get that population, is what I've been kind of told or hear about and so forth. Mm. So like I said, it's not always a bad thing.
Well, I mean, I've just been taken some mental notes. I'm sure our listeners are just going to enjoy this very much. And I think we should definitely have you back on because I think both Andrew and I have like a ton of additional follow-up questions. But we really do appreciate your time and your knowledge in teaching us, and also for your appreciation of hygienists being the front line.
Oh, absolutely. Absolutely. Let me tell you, I guess having a perio background, that makes you really, really appreciate the hygiene world. I mean, and like, again, I say, you guys are our first lines of defense and certainly do an awesome job. And I certainly, want to help out in any way, and I guess maybe give information out that may be helpful for you guys. So
if anyone wants to contact you or maybe has any follow-up questions, what's a good way to do that?
You can just email me at BryanGreenDMD@gmail.com, and that's BryanGreenDMD, that's David, Mary, David, @gmail.com.
Thank you. We really do appreciate your time and all of the knowledge that you provided with us today.
Absolutely. My pleasure. Thank you for having me.
I mean, I'm sure you guys were like, ask this, ask that. And we wanted to. We promise you.
I know. We did. We really did. It was on the tip of our tongue, but we ran out of time.
Yeah. And as much as I would make these Joe Rogan long form podcasts, Andrew doesn't let me do that.
No one else. Okay. We don't even get into it, but yeah.
Just me. So we also want to thank PDT because they were sponsoring the CE portion of this. And if you guys are going to be at ADHA, which this podcast is coming out the week of ADHA, make sure you come find us. We will be at the PDT booth on Saturday at 9:30 a.m. If you've heard me talk about the Gleason Guide, if you've heard us talk about the Queen of Hearts or the Montana Jack, and you want to see it and learn it and touch it and feel it and all that, do it then. Check them out. And if not, just ask your dealer, your Patterson, your Hinge Shines, your Bencos, whatevs. Ask them about it.
Sounds bad when you say it, the dealer. Just ask your dealer. The one on the street that you get all your drugs from.
Your scalar dealer.
They know it all.
On the corners. Anything else that we can think of?
I mean, Under One Roof's coming up. We have the IFDH in Australia that we'll be at. There's a chance that we might even be over at Dentsply Sirona World coming up in October. So, I mean, if you guys are at any of these conferences, just let us know.
Oh, and ADA in San Fran.
Oh, yeah. It's going to be a big one, too.
Because it's going to be a trifecta of CDA North, FDI, and ADA. So it's going to be a really big meeting. So if you're going to be there, we'd love to see you as well. And keep sharing your stories with us. Keep telling us how much you love particular guests or content, or even have suggestions. We will take them. And don't forget to give our guests the love that they deserve, because they come on here and share their knowledge. And we are so appreciative of them making us better clinicians. And if you want to follow us on Instagram or Facebook, please do that. You can also send us direct messages there. And check out our website, ataleoftwohygienists.com. And you can also send us an email, ataleoftwohygienists@gmail.com, or to us individually, Michelle or Andrew at ataleoftwohygienists.com. Anything else?
Yeah, that's it. Have a good week, everybody.
Bye, y'all.